So this part of the presentation is going to focus on neuromuscular or muscular disorders such as cerebral palsy, spinal muscular atrophy, and then Duchenne's muscular dystrophy. So cerebral palsy is a group of permanent disorders of the development of movement and postures causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. Cerebral palsy involves disturbances of sensation, perception, communication, cognition, and behavior, and secondary musculoskeletal problems. And then anywhere from 15 to 16% of those affected with cerebral palsy also have epilepsy. This is characterized by early onset and impaired movement and posture. Cerebral palsy is the most common permanent physical disability in childhood. And cerebral palsy can vary in degree of dysfunction. Now, the etiology of cerebral palsy, the prevalent traditional hypothesis is that cerebral palsy is caused by perinatal problems, especially birth asphyxia. But now it's believed that cerebral palsy results more often from an existing prenatal brain abnormality. The exact cause of these abnormalities are still elusive and not really known. 70% or the majority, 70 to 80% of cerebral palsy cases are caused by unknown prenatal factors. So really any prenatal, perinatal, or postnatal factor may contribute. And some of these things include maternal and perinatal infections, prenatal, postnatal hypoxia or asphyxia. Again, there's often no identifiable immediate cause. But then extremely low birth weight and then very low birth weight in infancy or infants continues to be the single most important risk factor for cerebral palsy. A cerebral hemorrhage can be a cause. And then postnatal infections such as meningitis, viral encephalitis, child abuse or shaken baby syndrome, and then anoxia, which is the most common cause of brain damage whenever it occurs. Often cerebral palsy is associated or has associated impairments. So they may also have seizures, hearing or vision impairments, behavioral impairments, communicative, cognitive deficits, oral motor, and then speech dysfunction. So these are the clinical classifications of cerebral palsy based on the primary type of movement disorders. So the most common clinical type is spastic. So spastic is persistent primitive reflexes. They'll have a positive Babinski reflex, ankylosing, exaggerated stretch reflex, and then eventual development of contractures. And this accounts for about 70 to 80% of all cerebral palsy cases. Then there's your dyskinetic, which you'll see chorea or involuntary irregular jerking movements characterized by slow writhing movements that usually involve the extremities, trunk, neck, facial muscles, and tongue. Children with this type of cerebral palsy also have poor suck and drooling. Then there's your ataxic kind, which these children will have wide-based gaits, rapid repetitive movements that are performed poorly, disintegration of movements of the upper extremities when a child is reaching for objects. And then you'll have your mixed or your dystonic type. And this is a combination of your spastic and dyskinetic cerebral palsy. It's also classified by 4 major dimensions. So motor abnormalities, associated impairments of seizures, hearing or vision impairments, behavioral, communicative, cognitive deficits, oral, motor, and speech dysfunction. And then anatomic and radiologic findings. So white matter on brain or having a brain anomaly. And then causation and timing. So maybe having a clear cause or a postnatal event such as meningitis and a traumatic brain injury. So diagnosis is made primarily by the neurologic exam and history. And often now neuroimaging for a child with suspected brain abnormality. So at the time of diagnosis, some early signs of cerebral palsy are poor head control after age 3 months, having stiff or rigid limbs, arching or pushing back, or arching their back and pushing away, having floppy tone if they're unable to sit without support at the age of 8 months, and then having clenched fists after 3 months of age. Listed here also are just the clinical manifestations. So having delayed gross motor development, abnormal motor performance, and a list of what that looks like, and then alterations of muscle tone. So increased or decreased resistance to passive movements, maybe having posturing, they're stiff, they're rigid. So again, just review these clinical manifestations. Additional clinical manifestations, that abnormal postures, so clenched fists after 3 months, arms are abducted at shoulders, elbows can be flexed. You have reflex abnormalities, so persistent primitive reflexes, tonic neck reflex at any age, persistent or hyperactivity. So really, these are all persistent primitive reflexes. Having ankle clonus, having associated disabilities, so altered learning and reasoning, maybe having seizures, sensory impairment, and then impaired behavioral and interpersonal relationships because they're not able to communicate as well, or if they do have issues with communication. And again, some of those like early signs are having excessive, which I'm going to go over, possible behavioral signs of cerebral palsy. So having excessive irritability, no smiling by age 3 months, having feeding difficulties, so persistent tongue thrusting, and then frequent gagging or choking with feeds. Now, therapeutic management of cerebral palsy. So the goal is early recognition and promotion of an optimum developmental course. This is a permanent condition, so the therapy is symptomatic and preventative. So we're trying to prevent some of the other things that can occur, like those contractures. Aims for therapy, if we can, establish locomotion, help with communication, integrate motor function, provide educational opportunities, and promote socialization experiences. You may see different types of braces or support to help prevent or reduce deformities of lower extremities and help increase the energy and efficiency of their gait and control alignment. Really early recognition and promotion of an optimum developmental course allows the child to attain their potential with their full potential within their limits. Other things with therapeutic management. So for mobilization, so having ankle foot orthoses or AFOs, maybe assisted devices to help them become more mobile using wheelchairs. So often you'll see surgical interventions such as tendon lengthening to improve function and spasticity, because spasticity can cause deformities and contractures. Medication are used to decrease overall spasticity. So you may see the Valium and baclofen to reduce that spasticity, or they can have a baclofen pump. Often, because seizures are often associated with many cases of cerebral palsy, so trying to decrease that seizure activity with medications such as Lamictal or gabapentin, and technical aids, so maybe microcomputers and voice synthesizers to help with communication. So nursing management is really to reinforce their therapeutic plan, do our assessments, help with ADLs. If they have difficulty eating, helping with gastrostomy feeds or G-tube feeds, administering medications, and assessing for skin breakdown, helping them turn, helping them move and reposition. Assisted normalization, helping families find support groups and work with coping mechanisms. And we really need to advocate for continued therapy of the child when they are hospitalized. So if they are getting supportive services like speech and PT and OT, making sure that those are still ordered so they can continue with their plan even while they're hospitalized. Now we're going to take a brief look at spinal muscular atrophy. So there are 3 different types of spinal muscular atrophy, or SMA. These disorders are characterized by a progressive weakness and wasting of skeletal muscles and muscle weakness. They vary based on severity of weakness and age of onset and clinical course. So, spinal muscular atrophy type 1, or Wernig-Hoffman disease. So, this is an autosomal recessive trait. It's the most common paralytic form of floppy infant syndrome, or also called congenital hypotonia. This is progressive weakness and wasting of skeletal muscle. Age of onset is variable, but this usually occurs before 2 years of age. And so some of the clinical manifestations of type 1 that you will see are an infant lays or lies in a frog position. They have a weak cry, cough, and generalized weakness. Active movement is usually limited to just their fingers and toes. They're cognitively aware, and they do have sensation. And unfortunately, with most of these type of cases, or with type 1, life is shortened and death usually does occur by about age 2 years. So this is diagnosed by electromyography and a muscle biopsy. But genetic analysis has become the gold standard for diagnosis. There is no cure for SMA, but treatment is symptomatic and preventative, predominantly preventing contractures and then treating orthopedic problems such as scoliosis. Nutritional growth failure may occur due to poor feeding, so G-tube feedings may be needed for nutritional support. Restrictive lung disease is a serious problem, and upper respiratory infections are common, so treatment with antibiotics is often necessary. And as mentioned, there is no cure, but treatment is symptomatic treatment, and it's supportive treatment. We want to prevent vigorous treatment of any infections. Like I'd already said, treatment of orthopedic problems, especially scoliosis. And prognosis does vary with the age of onset, but with type 1, as mentioned previously, they often do die from respiratory infections or failure between about 1 to 24 months of age. Some can live longer. Many of these children will need a tracheotomy, and they are often given some medications such as valproic acid and gabapentin that have been shown to slow the progression of the condition. And now the last condition that we're going to talk about is Duchenne's muscular dystrophy. So with muscular dystrophies, there is a gradual degeneration of muscle fibers, and it's characterized by progressive weakness and wasting of symmetric groups of skeletal muscles. In all types of muscular dystrophies, there is a loss of muscle strength, but each type differs based on the muscle groups affected, the age of onset, the rate of progression, and then the inheritance pattern. So the most common muscular dystrophy is Duchenne's muscular dystrophy, also called pseudohypertrophic muscular dystrophy. This is the most severe, but the most common of the muscular dystrophies in childhood. There is an X-linked inheritance pattern, and then one-third of cases actually result from fresh mutations. Some characteristics of Duchenne's muscular dystrophy include the onset being between ages 3 and 7 years of age. So you're going to see most children reach appropriate milestones early in life, and then they'll start to either kind of regress or not continue to meet milestones. You'll see progressive muscle weakness, wasting, and contractures. You can often see hypertrophic calf muscles in most of these children. Progressive generalized weakness in adolescence, and then often will have death from respiratory or cardiac failure. So diagnosis, can do prenatal diagnosis as early as 12 weeks of gestation. This is established primarily by blood polymerase chain reaction for dystrophic chain mutation. This is confirmed by confirmation by electromyelography, a muscle biopsy, and then serum enzyme measurement. Then you can have a positive family history and then a display of the usual characteristics of the disease. So some clinical manifestations or signs and symptoms that you will see with this is a waddling gait, having frequent falls, sorry about that, Gower sign, lordosis, enlarged muscles, profound muscular atrophy, it can have some mild to moderate mental impairment, and then obesity are common or are your clinical manifestations. So now this is showing the Gower sign. And so this is an image showing the Gower sign. So this is when a person or a child uses their hands to walk up, to walk up their body from a squatting position because of the lack of hip and thigh muscle strength. This is a classic characteristic, and if this is seen, they really need to be evaluated for Duchenne's muscular dystrophy. And then another visual of some signs and some symptoms that you may see with this. So therapeutic management. So we want to maintain function of the unaffected muscles as long as possible. So there is really no effective treatment established, and there's no cure that exists. But the primary goal, like I mentioned, is really to maintain that function in the unaffected muscles. Sorry, I'm having difficulties in the last of this presentation. Primary goal is really to maintain function in the unaffected muscles as long as possible. We want to keep the child as active as possible. We're going to do range of motion exercises, bracing, performance of activities of daily living, surgical release of contractures as needed, and then genetic counseling for the family. Often you're going to have a multidisciplinary approach, which is going to really help the child and family cope with the chronic progressive debilitating disease. We want to have a program for them that fosters independence and activity as long as possible. We want to help teach the child self-help skills and provide appropriate healthcare assistance as the child's needs intensify. So we may need to do home health, skilled nursing facility, respite care for the family. And so general focus of nursing care is that coordination of that multidisciplinary team, allowing independence, like I said, as long as possible, and really helping them and the family cope with this debilitating and fatal disease. So while they can live as normal life as possible, as long as possible, and provide some hope and support. So that ends this portion of the presentation, and I hope you all have a wonderful day.